Okay. All right. Well, good evening, everybody. I would like to introduce Dr. Jordi Blasco from Barcelona, who's kindly with us this evening to give us teaching on complex stroke management. As some of you will know, Jordi has been, he's a professor within the University of Barcelona, and he's written multiple publications on stroke management and was involved in the Revascat trial back in 2015. So Jordi, it's a pleasure. Thank you for all the teaching that you've helped with us in the past, and thank you very much for helping with the teaching again this evening. If it's all right, I could hand over to you, and thank you very much again.
Thank you so much. So good afternoon, good evening to all of you. First of all, thank you for your invitation. I'm really honored to be here to join you this afternoon. I'm gonna share my screen. So hold on a sec. Okay, hope you can see it right now. So thanks, Aubrey. You asked me to talk about complex stroke cases management, and I guess that many of you probably you're expecting me to show difficult scenarios with the angiographies and all that. That's not what I'm gonna show, and I'm gonna explain you. Sorry, I'm gonna explain you why. So this is the overview of the talk. We're gonna see what's a complex endovascular acute ischemic stroke treatment, how to avoid complexity, how to deal with complexity, and some conclusions. And the reason why I'm not gonna show you cases is because whenever I struggle with an acute ischemic stroke case, I always wonder, I always ask myself if it was really a complex case or my decisions, they were not right, and they made this case more complex than expected. This is the rationale of the talk. I think that the most difficult part of our job is not exactly how to do it, but to know what to do in every specific case. And whenever we talk about complex cases, I think that we have to think about the access. It's a very important point whenever we're dealing, especially with these kind of patients, that they're usually old patients. We're gonna talk about the clot location. Obviously, it's a much more difficult case whenever we have to deal with a distal clot. We're gonna talk as well about the clot burden, especially about the occlusions of the terminal ICA. For time constraints, we will not talk about dissections today, and also about the clot type. We are always taking a look to the NGCT. We see that there is a clot, but we don't have so much information about the type of clot we're dealing with. So let's start with the access. Access is success. We have to have it in mind, and the idea is how to get the best position for a successful mechanical thrombectomy, because the right technique is really the road to success, and the idea is to avoid, or at least to diminish, the number of complex cases. So let's see how to build the perfect access, how this access may influence the treatment strategy, and what we should know about materials and what to keep in consideration in the anatomy. Whenever we face an acute ischemic stroke case, we have many options. We all know we have to think about going femoral, going radial, either to place a balloon guiding catheter or not, to use a distal access catheter or not. Maybe we're thinking about the option of the trap technique, the badass technique, or whatever we call it, the use of stent reverse or aspiration, or even about the use of TPA in this case. So I would like to start saying that I'm an absolute defender on the use of balloon guiding catheter. However, whenever we take a look to these subaortic trunks of the CTA, in some situations, we may foresee that the possibility of placing after balloon guiding catheter is not going to be very easy. So these are, I wanted to show you here the main techniques in mechanical thrombectomy. Here on the left side, you can see the typical with the balloon guiding catheter, in this case with an intermediate catheter, that means a combined technique. Here we've got the simple technique, we can call it like that, with balloon guiding catheter and only a stent trigger. Here we can see the non-balloon guiding catheter technique with contact aspiration plus a stent trigger. or the adapt technique. And the only one that I do not recommend is the one that you can see down here, which is a conventional guide catheter or long sheath, only with the stent trigger without the use of intermediate catheter. And I don't recommend it because many papers have shown us that the results with these techniques, they are not as good as with the other ones. So basic questions before proceeding with an acute ischemic stroke procedure. Think about your favorite approach. It's very clear for me that the one that you are used to do is the one that is the best in your hands. So it's very important, obviously, to check your numbers to see that your first pass effect is good enough. But if it's like that, think about this approach. Second question, is it going to be doable, this approach in that specific patient? Should you forget maybe about this favorite approach in this specific case that you are facing? And what kind of access should you use to get the best support and the best result? Because I always say that it's important not to waste time. Time is still brain, it's very important. But when I take a look to the CTA and maybe it takes 2, 3, 5 minutes, in that situation, you're not wasting time, you're just saving time, because this will allow you to decide the best approach for that specific patient. So this is my favorite one. Usually I place a balloon guiding catheter in, let's say, 90% of the cases. I use a distal access catheter in many situations, and I always use the stent trigger as the first approach. This is what I do. I first check the CTA anatomy. I check the subaortic triangle origin, look for elongations, kinking, how is the carotid bifurcation. Here you can see our numbers. We've got a registry in which we have 15 comprehensive stroke centers involved in Spain. It's called Rossetti Registry of Combined versus Single Thrombectomy Techniques. And here, these are our numbers in my institution. So you can see that almost in 90% of the cases, we're using balloon guiding catheter. Obviously, when you take a look to these CTAs, depending on the angle, depending on the origin of the subaortic trunks, it's going to be important to decide the right approach. So in those cases in which we have the origin of the subaortic trunks very, very low here in the ascending aorta, maybe the radial approach is going to be better, or depending on the angulation that you've got here, maybe you think that the balloon guiding catheter is not going to be the best option. However, when we think about the balloon guiding catheter, we have to remember that it provides flow arrest, and I think that's very important to get a good result. It also provides proximal aspiration, depending obviously on the outer diameter of the intermediate catheter, if you're using that. And it may increase the support when we inflate the balloon, so it may help you to go up there with the microcatheter. In this publication, they show that it's very important in those situations in which we have an important amount of clot here at the level of the terminal ICA, to try to inflate the balloon and to aspirate, because maybe you're going to be able to get out all the clot, or at least you're going to diminish the clot burden that you have, and it's going to be easier for the stent trigger to retrieve completely the clot afterwards. The other important point is that we have to remember that there is a gradient of pressure in which we have the antegrade flow, the systolic pressure, and we also have the backwards flow from the collaterals. So in this situation, when we inflate the balloon, when we perform the aspiration, we are diminishing the systolic pressure, and probably the possibility of retrieving this clot is going to be easier. So this is one of the important points of the balloon guiding, to block the flow at this level. It's even if we use different techniques, I think that we would all agree that these things that you can see on the left side are the ones that we want to achieve with our technique. We want to have better clinical outcomes. Obviously, we want to have better angiographic results with lower infarct sizes and volumes, with the higher rates of first pass success, shorter procedure time, less rescue therapy, less distal emboli, very important, and better flow reversal. And all these things we have seen in many, many papers that they are achievable when we use balloon guiding catheter. So that's why I think that this is the best option if feasible. We have to remember that it's not suitable enough for radial access. Nowadays, these catheters, they have not been designed for radial access. So even if we can see in some papers that they have shown us that it's feasible, I think it's not the best option nowadays. And it's not suitable enough when we have elongated supraortic trunks. So if we find severe tortuosity and still think balloon guiding catheter is mandatory, the other option that we have is to use a quadraxial approach. This is something that we don't usually use, but it's something that you have to keep in mind. So you can go with a long sheath and then inside to place the balloon guiding catheter, a diagnostic catheter, and then this option is going to give you much more stability. What happens if we don't use balloon guiding catheter? Because if we take a look to this slide, you can see that in our registry, we've got around 41% of cases in which people, they have not used these balloon guiding catheters for different reasons. In these situations in our registry, what we have seen is that the most frequently used guiding catheter is Neuromax. These long sheaths or guiding catheters, good things, they provide extra support and better trackability, probably compared to balloon guiding catheters, and they have larger inner diameter. So anyway, watch out for kinkings whenever we use them. When we go to the posterior circulation, usually we use a 6 French catheter, a chaperone or wrist or benchmark, whatever you have. Pros and cons of these guiding catheters. First of all, again, you have no flow arrest. So I think there is a need for an intermediate catheter for distal aspiration and pinching of the clot. I think this is mandatory when we're using this technique. And it allows us to use a larger inner diameter distal access catheter, although there are still controversial results regarding the importance of this distal access catheter internal diameter. In our registry, again, we saw that more than 50% of the cases in which we were not using balloon guiding catheters, Sophia or Sophia Plus intermediate catheters were used. And the reason I am explaining all of you these is because right now I think that the point is not to open the vessel, because I think we're able to open the vessel in a very high percentage of cases. But these guys, some years ago, they told us about the first pass effect, and this is what they explained us. They told us they were comparing the first pass effect, which means that in a single pass or a single use of the device, we achieve a TK3 or a TK2C with no use of rescue therapy. And they compared the results with those situations in which we achieve a TK3 with any number of passes. And I think that in those cases, we are quite happy because we have opened everything, or even in those cases in which we have what they called modified first pass effect. That means a TK2B with the first pass. And this is what they showed us. These are the results of the full nasal registry with 354 cases. So 42% of a good clinical outcome at 90 days. That it was similar. It was 44% in those cases in which they achieved a TK2B at the end of the procedure, which is still considered to be a good result. And they had a 52% in those cases in which they had a modified first pass effect. That means one pass, TK2B. So when they compare these numbers to the first pass effect, and let's see that in this cohort, they only achieved this first pass effect in 24% of the cases, they had a 61% of good clinical outcome. And same happened with mortality. Here you can see in the total cohort, 30% of mortality, 30% as well with modified TK2B at the end of the procedure, 31% with a modified first pass effect, and only 16% of mortality in those cases in which they achieved a total revascularization in first pass. So that means that this is the goal. This is what we have to look for when we are designing our technique. We do not only want to open the vessel, we want to open it completely, and we want to open it with the less number of passes, because there's also this paper that showed us that more than 3 passes of a centrifuge is an independent predictor of parenchymal hematoma in acute ischemic stroke. Okay, so let's go for it. Let's design the technique. Let's design the approach that is going to give us a higher rate of first pass effect. As I was telling you before, in our cohort, in those situations in which we did not use balloon guiding catheter, The first pass effect with Sophia, which is a 5 French catheters, you all know, was 35%. And when we were using Sophia Plus, which is a higher inner diameter intermediate catheter, the first pass effect was 45%. Okay, so let's say that in our cohort, Sophia and Sophia Plus were the main distal access catheter when we were not using balloon guiding catheters. That first pass effect in non-balloon guiding catheter was lower than in balloon guiding catheter. That's why my first approach is with balloon guiding catheter. And that in these non-balloon guiding catheter procedures, Sophia had a 35% of first pass effect versus Sophia Plus with a 45%. So what happens when we mix this balloon guiding catheter with an intermediate catheter? First of all, it allows us for better stability when we have severe curves at the level of the internal carotid artery, and it allows us to perform the combined technique. So in this drawing, you can see both options. So on the left side here, you can see the balloon guiding catheter with a classical approach, only with a centrifuge. On the right side, you can see the balloon guiding catheter plus the intermediate catheter plus the centrifuge. And I was a defender of this approach. I think that we've got everything when we're using this. We have higher odds of achieving this first pass effect, and that's why we designed an analysis of our cohort in which we wanted to evaluate if one approach was better than the other when we were talking about anterior circulation acute ischemic stroke procedures. And this is what we concluded. We saw that our data, when we were comparing balloon guiding catheter plus centrifuge or balloon guiding catheter plus combined approach, meaning intermediate catheter and centrifuge, did not result in higher rates of first pass effect or in improved clinical outcome. So I was a bit surprised, but not that much when I saw the results of this randomized clinical trial, the ASTER-2 trial, in which they found the same results that we were seeing in our cohort. So they told us that comparing both techniques, and they did not see any significant improving in the rate of near total or total reperfusion when they were using this intermediate catheter. Remember that we are only talking about balloon guiding catheter procedures. Okay, the other important point that I think that we have to keep in mind when we talk about intermediate catheters is that we simply say, okay, we have used it or not, but it's completely different if we're not able to get to the face of the clot. Sometimes we have some problems at the level of the ophthalmic artery, and in this situation, as you probably know, it's very important to use, for example, the centrifuge as an anchor in order to be able to pass through the ophthalmic artery with the intermediate catheter, because when we use the intermediate catheter with a balloon guiding catheter, we don't have to forget that we are losing aspiration power proximally at the level of the balloon guiding catheter. So if we lose this power of aspiration at this level, it's very important that we are able to go with the intermediate catheter to the face of the clot in order to have proper aspiration at that level and to pinch the clot properly, okay? So in many circumstances, if we ask someone, have you used the intermediate catheter? They tell you, yes, I have used it. That's not the only important point. The other important point is if you have been able to take it to the place it has to be to work as it should, okay? So how to build a perfect access? Perfect access is the one that allows us for better first pass effect and complete revascularization rates. Balloon guiding catheter still seems to provide better first pass effect. Better stability for these procedures may be achieved with a quadriaxial approach whenever needed. And that balloon guiding catheter sometimes may be non-doable in elongated vessels or with acute angle at the origin of the supraortic trunks. So in these elongated or angulated supraortic trunks, long sheets or guiding catheters may provide better stability. So you may use them in this situation when you take a look to the CTA. If non-balloon guiding catheters are used, remember that extra large distal access catheter may compensate the absence of flow arrest and proximal aspiration. That in this situation, access devices may kink, so support and stiffness as well as navigability are important features nowadays. The distal access catheter that we're using is the either the catalyst 6 or the I can't remember the name right now from Cerenobus. I'm going to tell you later if it comes to my mind. Some cases may not be performed with femoral access. So always when you take a look, think about radial sometimes. And in those cases in which you have gone through femoral, it's very important not to delay the treatment. If you see that it's not possible through femoral, you should switch to radial and not after an hour trying to go up there through the femoral. And sheathless guiding catheters may work better for radial. We're using frequently the wrist catheter. Always very important, take a careful look to the subaortic trunks anatomy on CTA. It's not a waste of time. You're saving time. Decide if you're able to perform your standard approach, the one that you perform usually, the one that you do better. In elongated ICA at the level of the cervical part, think about intermediate catheters for better and easier microcatheter navigability. And in elongated subaortic trunks, take the approach that will give you better stability. That means balloon guiding catheter plus intermediate catheter or long sheath. And think about radial, although nowadays, as I said before, it's not a good option when you're thinking about balloon guiding catheter. So once that we have talked about the access, let's talk briefly about the clot location. We all know that it's not the same when we've got an M1 occlusion that when we're talking about the distal occlusion. So let's talk about MEVUS. This is a proposed definition in this paper that they gave us for MEVUS. And it both the anatomical point of view and the functional point of view, you have to take into account. So we're talking about occlusions at the level of the M2, M3, A2, A3, P2, and P3, with an NIH more or equal to 5, or when it's less than 5 with a disabling deficit, okay? And we all know that it's completely different. Again, even if we try to put the same name for all these occlusions, it's not the same when you've got a clot here at the level of the P2, or you've got a clot at the level of the distal M2 or M3, and completely different if you're going to the inferior trunk of the MCA or the superior trunk. And the superior trunk, we've got more angulation. So it's not just a question of how far is the clot, but how difficult is it to get to the clot, how many angulations you have in order to place your microcatheter right there. What about MEVUS? Remember that we've got the primary MEVUS, so they are de novo. You can see them on the CTA, and they have a similar etiology to large vessel occlusions. And we've got secondary MEVUS that we have to avoid. That means that we have had a migration or a fragmentation of an LVO. So we may have a new territory distal emboli or distal embolization in the same territory than primary occlusion. And when we talk about secondary MEVUS, we have to think that maybe spontaneous, but most of the cases they're iatrogenic, either due to the endovascular treatment or due to the thrombolysis. We also have the synchronic MEVUS, so that means that we have simultaneous occlusions in different levels, what we call usually the embolic shower. And we have to take a look to the prevalence and the outcomes of these MEVUS when they have discrepant infarct patterns. What does it mean? Here they were comparing the clinical outcome of those patients with primary MEVUS versus those with secondary MEVUS. And you can see that the MRS 0, 1, or 2 was completely different. So almost 71% in those MEVUS that they were primary, they were de novo, compared to 56% with those secondary MEVUS. And the same for the excellent clinical outcome, meaning MRS 0 or 1 at 90 days. You can see 53% in those primary MEVUS versus 40% in secondary MEVUS. So the idea, it's very, very important that the technique that you use is able to avoid the clot fragmentation, because the clinical outcome is gonna be completely different for your patient. What else in this paper published by the group of Amrusa Ra? Here you can see it's a multi-center retrospective cohort study of patients with acute ischemic strokes in M2 segments from 10 US centers. And here they told us once again that it seems that endovascular treatment is better in terms of clinical outcome than medical management without an increased risk of symptomatic or asymptomatic intracranial hemorrhage. So this is why the guidelines, what do they say? They say that if we're talking about an M2 segment or M3 segment, it may be reasonable to do mechanical thrombectomy. Same for the anterior cerebral arteries or the posterior cerebral arteries. And finally, the idea is that mechanical thrombectomy is reasonable in this situation. But I would say that whenever we've got an M3 occlusion or an A2, A3 occlusion, I would say that we have to tailor our decision-making process, okay? We have to see if it's really difficult to get there or not that difficult, if it's very far away or not, the symptoms of the patient. If we've got penumbra, I think that in these situations, it's also important to decide if we've got a deficit, that it's very important for the patient. So with all these things is when we make the decision to go or not go in to open the vessel with endovascular means. And what options do we have? With kind of techniques can we use in MIVOS? We can go with a simple technique that means balloon guiding catheter or non-balloon guiding catheter with a low profile stent trigger, usually a 3 millimeter. We can also go with low profile aspiration catheters, although as I told you at the beginning, I would say a stent trigger guide. And we can also use the combined technique, either with long microcatheters or with the blind exchange manipulating technique. That means that you go with the stent trigger, with a normal microcatheter, you retrieve it, and then you go with a longer microcatheter in order to do the pinching technique to catch the clot properly in order not to lose it when you're retrieving that clot. So conclusions of MIVOS, I would say that it seems reasonable nowadays to treat MIVOS with mechanical thrombectomy, that RTPA efficacy is limited. I don't know what will happen with new drugs in the future, that we still have limited data on efficacy and safety of mechanical thrombectomy in MIVOS, and that I hope that this trial, ESCAPE MIVO clinical trial or other trials that they're running right now, they will give us more data on how to proceed with these situations. I would like also to comment briefly on the use of RTPA post-mechanical thrombectomy. We should not forget it, especially when we have a very distal clot, a very difficult clot to get there with a microcatheter. Think about it. I guess that you all know the CHOICE trial, which is a trial that we run here in our institution with some more comprehensive stroke centers in Catalonia. Right now, we're doing the CHOICE 2 trial. In this CHOICE trial, we wanted to evaluate if the use of intraarterial RTPA after a successful mechanical thrombectomy was safe and may improve the rate of excellent clinical outcome in patients with LVO in the anterior circulation. And I would say that the new idea about CHOICE is that we had some papers that they have shown us that the use of RTPA as rescue therapy may be a good thing. But in CHOICE, as you can see in this sentence, we used RTPA intraarterially in those cases in which we had achieved at least a TK2B, I mean a successful mechanical thrombectomy. And even in those cases, in which we had an excellent revascularization or reperfusion, at least in angiography, meaning that after the mechanical thrombectomy, we had the TK2C or 3, we saw that the results were very good, as I will show you in the next slide. So patients arriving with a clot in the anterior circulation, they were randomized for placebo or intraarterial RTPA after achieving a successful revascularization, again, meaning TK2B at least. And they were treated with either alteplase intraarterially or placebo, as I told you. And here you can see the results. And in those patients that they were treated with alteplase intraarterially, we had almost a 60% of good clinical outcome, of excellent clinical outcome, because it was MRS 0 or 1 at 90 days, compared to 40% in those patients with placebo. So it was a bit surprising for us. It was very interesting, getting us to the point that we have the no reflow phenomenon, in which even if we're taking a look to our final run and we can see that we've got a TK2B or a TK2C or 3, there are some problems in the microcirculation that may be improved with the use of RTPA. So we hope that we can confirm these results in choice 2, and I will be very happy if that happens, because RTPA or maybe another type of medication may help us in those very distal clots, in which we should keep in mind that the risks are completely different than when we are talking about doing a mechanical thrombectomy in a more proximal vessel. Okay, so let's go to the next step. What about the clot burden? Whenever we have a patient in which we have a lot of a big quantity of clot, especially in those cases in which we've got an occlusion of the terminal ICAs. So we've got different situations. We all know that sometimes the CTA may give us the impression that we've got a clot in the ICA at the cervical level, and that's not exactly true, because we can see the slow flow of the contrast, but the clot is up here, more distal or at the level of the bifurcation of the ICA. But whenever this happens, any of these situations, we all know that we have a big amount of clot, and it's not that easy, and it's supposed to be a complex case in many circumstances. Okay, so whenever we have this situation and we're using a balloon guiding catheter, as I showed you in the first slides, it's an interesting option to inflate the balloon and to do aspiration, because in some situations we're going to be able to completely retrieve the clot, or at least to diminish the amount of clot that we have right here, and then to go with the stent retriever. There are new techniques, as for example the double stent retriever technique. A few years ago, back in 2020, you can see this paper in which they showed us that in those situations in which we have a clot that it's at the level of the MCA bifurcation or at the ICA bifurcation, it seems that it may work quite well as a rescue therapy. But not only that, also as a first line in this publication from a Spanish group, they showed us that in those situations with terminal ICA occlusion or bifurcation at the level of the M1, double stent retriever thrombectomy may work better than a single stent retriever. So we're using it from time to time. It's not something that we're using on a regular basis, but maybe some more papers will give us more information about its usefulness. So here you can see this is a randomized in vitro evaluation of this technique by the group of Mark Ribot. And again, they showed us in this randomized in vitro evaluation that double stent retriever may work better than single stent retriever when we are treating bifurcation clots at the level of the MCA of or the terminal ICA. Other options that we have, big aspiration catheters, like for example the Jet 7 or other ones that we have in the market, they may provide us help for these situations in which the clot burden is very high. I've explained briefly something about this Rossetti registry that we have. It's a multi-center registry. Right now, we started enrolling patients back in 2019. Right now, we have more than 4,000 patients. It's supported by the Spanish group of Interventional Neuroradiology. It's self-financed, and it's an open access database for all enrolling centers. Here you can see all the comprehensive stroke centers that they enroll patients for the Rossetti registry. And I wanted to show you this paper that we are about to send to see if it's accepted. But I wanted to share with you the numbers, because I think it's quite interesting sometimes to see the numbers and to understand what's going on. Here you can see a whole cohort of almost 500 patients with terminal ICA occlusions, and most of them, more than 95%, 97% of patients treated with a balloon guiding catheter. So remember, terminal ICA balloon guiding catheter. And we wanted to compare not only the type of stent retriever, which you can see here as group 1, group 2, or group 3, depending on the size and the length of the stent retriever, but also on the use of distal catheter in these situations. And here, what we have seen, surprisingly, is that whenever we have a terminal ICA occlusion, that means a big amount of clot, and we're using a balloon guiding catheter, the use of distal access catheter is not good. I mean, it's much better to go with a stent retriever, a big stent retriever, a long stent retriever, and not using a distal a distal access catheter. And maybe this is because when we use this distal access catheter, we are preventing the proximal aspiration from the balloon guiding catheter. Probably this is the reason why the results are not so good when we use this distal access catheter. So we have to analyze it completely. We will send it for publication, but still we have more and more data to understand exactly what goes on when we put an intermediate catheter through a balloon guiding catheter. So here you can see that there is better results at TK2CO3 whenever we don't use this distal access catheter. So distal access catheter was used in 47% of the cases in which we achieved a complete revascularization, compared to 63% in those cases in which we did not achieve a good revascularization. And finally, I would like to finish with the clot type. We're always thinking that we've got there a stop on the CTA, but we don't understand exactly what type of clot we're facing. Maybe in the future, radiomics will give us more information about the type of clot to understand why in some situations we're able to take out that clot with one technique, and sometimes we're not able to do it. This is a very interesting paper about what is a challenging clot. We all know that those clots, they're white clots, they're not hyperdense on CT. Those calcified clots, probably they're gonna represent a complex case for us in order to achieve a complete revascularization. So should we use a different strategy? Should we use a different stent retriever design? Yeah, we're lucky. We're having lately different devices instead of the typical stent retrievers that they may help us as a rescue therapy, as for example, the NIVA device. We're using it in some situations with very good results, either as a first line strategy or as a rescue therapy. The Tiger stent retriever, which allows you to modify the size of the stent retriever at the level to do kind of massage at the level of the clot. And the most interesting one for me is the Nimbus from Theranovus, because as they told us, I mean, they sell it as a rescue stent retriever. So it's been designed in a different way. You do kind of pinching of the clot, and it works very well, especially in calcified clots, in those situations in which we know there is a calcified clot. Sometimes we try with a standard stent retriever, but whenever we have changed to Nimbus, we have been able to open it. So we're thinking about going as first line device in those situations in which we take a look to the CTA and we can see some clot right there. So I will finish with some conclusions. First, minimize complex cases, designing your strategy in advance based on CTA, anatomy, type of clot, etc. Avoid multiple passes and distal emboli using the right approach, because you will have worse clinical outcomes in your patients. If you've got a MEVO occlusion, tailor your decision-making process, avoid complications. Remember that it's completely different, the risks, when you're dealing with an M3 occlusion. Think about alternative and different options when primary approach does not work. Remember choice trial that suggests TPA efficacy in improving clinical outcome after successful mechanical thrombectomy, or in those situations in which you have small clots in different vessels. So it's useless to go there with a stent retriever in 3 different vessels. So in that situation, probably intraarterial drugs may help us. And I didn't want to finish at least with one case that maybe you're waiting for. And this is a very fresh case made today, in which we were dealing with these images. So first of all, occlusion at the level of the ICA, proximal ICA. We couldn't see the exit of this occlusion, so it's not easy to find where to pass through with the guide wire, and with tandem occlusion at the level of the M1. Okay, so in this case, we went with a balloon guiding catheter. We tried to go through with a standard 14 guide wire, first with a synchro, then we changed to a Spartacor, which is the one that we use for for carotid artery procedures. It's a steeper guide wire we couldn't pass through, and then we decided to go with a diagnostic catheter, going to the point of the occlusion and trying to go with a 035 Terumo guide wire, and it was very easy to pass through. There's always the discussion about if going antegrade or retrograde with tandem occlusions. It means, should we open first the carotid artery at the cervical portion, or should we go, once we have passed through these occlusions, should we open first intracranially, because it's the problem is right there, especially in this patient I'm talking about, because patient had quite good collaterals for the circle of Willis. So in this case, we passed through the stenosis with the Terumo 035. We changed it for a 14, and then we perform angioplasty, and we went for the MCA occlusion. Here you can see the lateral view. Here you can see the stent retriever, which was a 4x41, and the intermediate catheter, which was really pushed forward against the clot in order to perform the pinching of the clot and to perform aspiration. Here you can see the balloon guiding catheter with the inflation, and this is the result after one pass. So it looks quite good in the AP view. In the lateral view, you can see that there is some stagnation at this level. You can see it right here. So I would call this a TK2C probably. So almost 90% of reperfusion. This is how it looked like after the angioplasty, after we had achieved the revascularization at the intracranial level. And with this appearance, we decided to stent it. We went with a wall stent, and this is the final result. So I think this is the typical case in which we would say it's going to be complex, but sometimes if we take the proper decisions, the percentage of cases that finally they're going to be really complex, it's going to be lower. So this was the purpose of my talk, to try to help you to diminish the number of complex cases that you're going to face based on wrong decisions. And I think this is the last one. So thank you very much once again, Aubrey, for your invitation, and I'm open if anyone has any comments or questions. Thank you.
Thank you very much, Jordi. That was a fantastic talk, and thank you for all your insight and all your knowledge that you've passed on to us this evening. Just a question for all those who are logged on. Does anybody want to ask any questions to Jordi whilst we've got him?
I guess they were all expecting cases, huh?
Yes, would you like to ask?
Yeah, sorry. I'm very interested in your study with the intraarterial alteplase, and I just wondered, because I didn't catch the beginning of the methods on your slide. Is this in patients that have had IVT, or patients that have not had IVT?
Yeah. I mean that was not a problem. Some of them received IVT if it was okay for them. So there were not contraindications for the intraarterial TPA after IV treatment. No problem. We were quite concerned about that. Obviously, we were not very happy as interventional neuroradiologists to place some TPA intraarterially after we had a TK 2B, 2C, or even 3. But the results were there, so we're happy about it. I think that the point is that we're not able to see everything with the angio, obviously. So we see the main vessels, even tiny vessels, but we don't see the microcirculation, and maybe that's the point where RTPA is working. Probably, I don't know.
Great, Waleed.
Hi, just to follow up on that, on the IA lysis. So what dose do you give, and where do you place your microcatheter in relation to the clot, and how slowly do you infuse the alteplase?
Yeah, that's a very important point. We were not sure about the dose. If I remember it correctly, I think it was 0.225 per kilo. But the idea was that first of all, we started with the injection through the microcatheter in the first cases. We wanted to go distally from the origin of the lenticular-striate arteries because we thought that the risk was going to be lower. Finally, I had some concerns regarding the fact that we were injecting through the microcatheter for 15 minutes. I think that we are in a prothrombotic state when we're dealing with an acute ischemic stroke patient. I was not very happy having a microcatheter inside the middle cerebral artery for 15 minutes. So we changed it finally, and we injected the RTPA through the guiding catheter. Okay, in order to avoid problems of clots at the level of the microcatheter. And to make it easier, obviously, because once you have retrieved the clot, you've got the TK2B or TK2C, we had no microcatheter, then to avoid to go up there again there with the microcatheter to stay for 15 minutes, then we change it. So at the end of the procedure, at the end of the study, or at the middle of the study, we changed it, and we were injecting the RTPA through the guiding catheter for 10 minutes. For 15 minutes, sorry, for 15 minutes.
Great, thank you very much.
You're welcome.
Brilliant. I've got a question, Jordi, just again regarding the intraarterial TPA. Is there a time frame in which you would give it? Would it be within the first 4.5 hours? Would you give it for patients later than that, outside that time frame?
Yeah, in the intraarterial, we were giving it in the first 6 hours.
First 6 hours.
First 6 hours, yeah. And IV was before, I think, for 4.5 hours. For intraarterial, we were putting 6 hours. But you can imagine, we all had concerns when we started the trial, not only us in my institutions, but because obviously the IP was from my hospital, so we had it more clear that we had to enroll patients, but we had some issues enrolling patients because you had to convince our colleagues that in those cases in which you had a good situation, let's say, with at least a TK2D, you had to inject something intraarterially. We were not very sure about the safety, but finally it worked very well. So I think we all have to learn from that. We all have to learn that sometimes things are not as good as they look like. And it's not only achieving a good revascularization, but also a good reperfusion, and especially a good clinical outcome. That's the point of all of what we do.
Brilliant. I think that's fascinating. So we're looking forward to the results now of Choice 2. And thank you very much, Jordi. Any other questions at all? All right, well, I call the end to the session. Thank you so much, Jordi, for offering your time and giving such an excellent teaching session. I'm sure I appreciate it. I know everyone else has appreciated it. And thank you very much again.
Thank you very much for inviting me. Thanks a lot. Nice to see you all.
Oh, yeah, you take care. Thank you very much. Thanks, everybody.
Thank you. Take care.
Bye.
Good evening. Bye-bye.